So, good evening, everybody, and welcome to OrthoTV. I'll hand it over to our moderator, Dr. Sergio, for further proceedings.
Okay, so can I start now? Yeah. Okay, lovely. So, hello, everybody. This is me, Dr. Sergio from Brazil, from Show the Planet, together with OrthoTV. Welcome, everybody, from many places around the world, especially from India. This is our first webinar of the year, the 6th Indo-Brazilian Show the Planet and OrthoTV webinar. And this is going to be about something very interesting, which is scapular fractures from different perspectives from very good specialists. So I just would like to make some introductions and then we can start. We have here 5 gentlemen from Buenos Aires, Argentina, Dr. Daniel Moya, our good friend, as everybody knows, ex-president or president of 2019 International Congress of Shoulder and Elbow Surgery in Buenos Aires, Argentina. From Brazil, we have 2 lovely friends of mine, 2 very high-level trauma surgeons from both, they are from AO Trauma Group Brazil, Dr. Robinson Esteves from the city of Belo Horizonte, state of Minas Gerais, from Brazil. He's an outstanding orthopedic trauma surgeon, and from the famous city of Rio de Janeiro, a very famous surgeon too, Dr. Vincenzo Giordano. This is a very Italian name, who is quite known in AO Trauma Brazil about his knowledge in trauma in the whole part of the human body. We still have Dr. Parag Shah from India, our good friend. He's an upper limb guy. We know him a lot, and he's going to talk about different perspectives in scapular trauma and also fractures in the scapula after reverse arthroplasty, which is something that we are all very curious to see. Anyway, Dr. Daniel is gonna speak just some minutes about a new project that we are developing. He, me, and Dr. Ashok with Neeraj Bijlani from OrthoTV, which is a very bold, rock and solid project, which is called OrthoTV Iberoamerica. We are putting together 20 countries from 2 continents. This is happening mostly due to gigantic and immense efforts from Dr. Daniel. He is the keystone of all of this project and this idea from which I have the honor to be part of. So I'm gonna hand the microphone to Dr. Daniel. Just before that, I would just like everybody to say hello to our audience before Dr. Daniel starts to speak. So Dr. Robinson, please, can you start just saying hello to everybody, please?
Hello, Sergio. Hello, everybody. Thanks for inviting me. It's a huge pleasure to be here. Thanks, OrthoTV and Show the Planet. It's a huge honor to share this webinar with such recognized faculty.
Lovely. Dr. Vincenzo from Rio de Janeiro, you can give us your hello.
Thanks, Sergio. Thanks for the invitation again, once more. It's a pleasure to share this webinar with you, with my friend, my very good friend and brother, Robinson Esteves Pires, and also with Dr. Parag. I don't know him, but for sure we're going to have a very good webinar discussing this very interesting and hot topic. Thank you very much for the invitation again.
Okay, Dr. Parag Shah is having some problems with internet connection. He's coming in a few minutes. This is part of the game sometimes. But Dr. Daniel, so you just say hello to everybody and you can speak whatever you wish about our new project, OrthoTV Iberoamerica, and you can share your screen, please, Dr. Daniel Moya.
Thank you very much, Sergio. It's great to be here again and in this amazing webinar that I was not planning to stay, but I will do as much as possible to stay because sounds very interesting by experts on the topic. And this is in some way the style that we want for OrthoTV Iberoamerica. I will show you just a few slides. You all know OrthoTV that was born in India and is spread all over the world. But now OrthoTV authorities are looking to Iberoamerica, to Spanish and Portuguese speaking countries. And there is a really a new world to discover here. We already have the acceptation to participate by continental societies like the Latin American Shoulder and Elbow Society, the Shockwaves Society of Iberoamerica, also national societies like the Spanish Society of Rehabilitation and Physical Medicine, the Argentinian Society of Shoulder and Elbow Surgery, the Argentinian Society of Trauma, the Bolivian Society of Arthroscopy, the Society of Shockwaves and Tissue Engineering of Chile, and there are many other societies that are coming to join this effort to develop an ambitious plan of continuing education in orthopedics for all levels. This would be impossible without the generosity and the effort of Dr. Ashok, Dr. Sergio, and Dr. Niraj that you all know. And I think that is a chance to discover from people who are outside Ibero-Latino American countries, the enormous scientific production that is developed in these countries, and also the energy and the passion of Latin America and Ibero-America, Spain and Portugal. So we will be able to share knowledge, to develop friendship, and to share experiences from the two ends of the world. And it seems to me that this is a lot of work that is coming, but a great opportunity for all. Thank you very much.
Okay, so I just want to make a very, very fast comment because I think it's very important, and then Dr. Ashok wants to play a video about OrthoTV Iberoamerica. I would like to highlight 3 points, 3 words that we have said. So I said that it's a bold project, and yes, it is. And it's ambitious, as Dr. Daniel has said, in the best sense of the meaning. But the most important word, as Dr. Daniel has said, is friendship. So we are always together for the benefit of orthopedic education as friends. And this is the key word. So Dr. Ashok, you will play now a video, and I would like all the viewers to listen as high as you can, because I want you to feel it with your ears and with your eyes. So you can play, Dr. Ashok.
Thank you.
Okay, Dr. Ashok, do you want to say anything about OrthoTV Iberoamerica before we start the webinar?
I think it is really a very exciting project for us, and coming together of an entire continent together is, I don't think it is heard of in an academic community, and
Sure.
it is the first of its kind venture. Uh, like Dr. Daniel said, it's a hard work, but we are all ready to put in that hard work and take it ahead as much as possible. So, congratulations again to Dr. Daniel and Dr. Sergio, and we are going to do it as much.
Lovely. So, as I have said, the master of the story is not me, it's Dr. Daniel, and I just have the honor to be. And I just have the and I just have the honor to be on the same story. So the thing is now, Dr. Robinson, can you start? Or Dr. Robinson, what do you prefer? You to start, or Dr. Vincenzo? Because this is what we are gonna do. They are gonna talk about intra-articular fractures, and after that, neck and body. They work together. They know the rationale, and they have published recently a very important article about it. So having said that, Dr. Robinson, do you want you to start, or do you want Dr. Vincenzo to start? It's your choice.
You are the boss. You are the boss.
Jesus. Vincenzo, what do you think?
Start.
No.
What do you prefer?
No, I'm just thinking about the comprehension of the audience. So if you think it doesn't matter, you can start. But thinking about the comprehension of the audience, I don't know if going from extra-articular to intra is more interesting. I'm very serious now. Dr. Vincenzo, what do you think about it in terms of the audience to understand the topic?
Sergio, what I think the best is, according to our manuscript, our paper that you mentioned that we just published, I think we can start with Robinson. Following what we did in our publication, we started by talking about neck and body. And then we can talk a little bit about the articular fractures of the glenoid fossa.
Okay, so just for people to understand, and then I'm gonna be off during this presentation. This is what we're gonna do. We are gonna see the two presentations in a sequence, but then we are gonna discuss many things before Dr. Parag speaks, because the audience really likes all of these discussions. Okay, so I am turning my camera on to make the internet connection better for the presentation. And Dr. Robinson, you can start.
Okay, can you hear me?
Clear and loud.
Okay, thank you. So let's move on with the scapular, neck, and body fractures. This is my disclosures. And my goals in this presentation are to talk about a little bit about surgical indications, mostly about approaches, but moreover about fixation strategies. So this is a very, very interesting paper published around 10 years ago by Professor Peter Cole, and the authors have mapped these scapular fractures, and they found that the vast majority of scapular fractures reach the scapular body, spine, and glenoid neck, the yellow zone that we are going to address in this presentation. The first problem when dealing with a scapular fracture is that the scapular body fracture is usually a part of a blunt chest trauma. We rarely see an isolated fracture of the scapula. Actually, we really have to be careful when evaluating a patient with a chest trauma, looking for a scapular fracture, because it's very, very common to find out associated injuries, such as the rib fractures that are very, very, very common, pneumothorax, hemothorax, lung contusion, and these papers show that the presence of a scapular fracture is a predictor of severity of the trauma. it's not actually a predictor of death, but it's not a predictor of mortality, but it's a predictor of severity of trauma, and we have to be very, very careful when evaluating a patient like that. The second problem is the literature is extremely controversial regarding surgical indications. I have changed my practice over the 10 years, the last 10 years, the last decade in terms of treating scapular fractures, because maybe 10 years ago, I treated 100 of my patients conservatively. But we have some patients, I strongly believe that we have a portion of patients, around 20% of patients who will benefit of a surgical procedure, but we don't have a clear evidence of which is the exact group that will benefit from a surgical procedure. But I presume that from 12 to 20% of patients, we need surgery, and for the vast majority, 80% of patients, we can safely and effectively manage using the conservative treatment with a very, very good results. I follow to treat my patients surgically and to indicate the surgery. Actually, I use this protocol from the Minnesota group, from St. Paul group, from the Scapular Institute, from Professor Peter Cole and colleagues. And the indications, in my opinion, are an articular gap or step greater than 4 millimeters, involvement of more than 20-25% of articular surface of the scapula, medialization of the scapula over 20 millimeters, a glenopolar angle inferior to 22 degrees, and some degree of angulation over 45 degrees, or depending on the case and combination or deformities, 30 degrees of angulation. But we have in the literature several papers showing poor outcomes, functional outcomes, when the glenopolar angle is inferior to 22 degrees. But this paper, published 3 years ago by a dear partner, a dear friend, Pedro Labrunici, and we have participated as well together with Vincenzo. Pedro showed that some degree of rotation of the scapula can significantly decrease the measurement of the glenopolar angle. And consequently, we are going to indicate a surgery incorrectly. So it's important to emphasize that the correct way to measure the glenopolar angle is with a 0 degrees of rotation of the scapula in neutral position. Another problem when dealing with the scapular fracture lies on the complex approaches with a long learning curve in surgical procedures, mostly extensive soft tissues dissections, and of course, a potential risk of neurovascular structures damage, such as the suprascapular nerve, artery, sometimes the axillary nerve because of the traction of the soft tissues retractors, and we have potential structures at risk when doing these approaches. The fourth problem is the anatomy of the scapula is unfavorable for implant placement. And we have a very flat and very thin bone, mostly in the body of the scapula, and we don't have a very good area for a good purchase between the screw and the bone, such as in several other bones. And another problem is the reduction of the scapula is not easy depending on the fracture pattern. And if you perform an adequate reduction, how to maintain this reduction? Because if you have a distal humerus fracture, we can easily perform the reduction and insert some K wires to maintain the reduction. But how to do it in a flat bone, in a very thin bone? moreover, we don't have, at least in Brazil, in our daily practice, we don't have a fancy, modern, very expensive implants to treat scapular fractures, and the mostly and in the vast majority of cases, we have to customize our treatment using unconventional implants to treat this kind of fracture. Because of this, some years ago, we have started doing the use of mini fragment plates. This is a paper of my partner, my dear friend Vincenzo. And we currently use a lot of mini plates, mini fragment plates from the foot set, from the hand set, in complex peri-articular fractures. In the scapula, we use it a lot, of course. Doing a fragment-specific fixation to maintain the reduction, but when we apply several plates in the same bone, besides maintaining the reduction, we increase the stability of the construct, and we allow the patient for starting an early range of motion with low pain. Regarding approaches, we have several possibilities. This is the classic approach to treat the scapular fractures. It's a very extensive and soft tissues demanding approach, the classic Jude, the Burmerang skin incision, and we recognize that it's a very extensive approach, and we reserve the Jude approach currently for late fixations more than 3 weeks, and for the rare malunion of the scapula when an osteotomy is required. This is a patient, one of my first cases of scapular fixation. This is a male patient, 34 years old, motorcycle accident, construction work, non-dominantly, but this patient presented a very low glenopolar angle, more than 20 millimeters of medialization of the scapula, articular involvement. And this is my patient positioning, my preferred patient positioning. We can do it in prone, but I was trained doing this fixation with the patient in lateral positioning. Usually put a roll in the axillary area, and I put the patient with the chest slightly anterior and with the arm free to be mobilized over a pillow in 90 degrees with the chest wall. And this is my preferred patient positioning. We can see here the classic Jude approach. I recognize a very demanding soft tissues detachment of the infraspinatus, mostly the deltoid takedown, but you can see here a very demanding retraction, putting Holman retractors over the lateral pillar of the scapula, but you can see a fragment-specific fixation. Currently, I think it's much more important to assemble the puzzles in the periphery of the scapula, in the lateral pillar, in the medial pillar. I think currently that's not too much important to assemble all pieces of small bones, mostly in the central part of the scapula, but it's a way. Sometimes you have to do it, especially when we have a displacement in 90 degrees in some fragments of the central area of the body of the scapula, and because these fragments can cause some entrapment, especially over the subscapularis muscle. Despite of a huge soft tissues detachment, we can reattach all the muscles over the supraspinatus, the deltoid muscles, and we have a very huge approach, but the result is nice. You can see here the patient is still with the stitches, but starting passive assisted range of motion, some degree of seroma that is very common when using the classic Jude approach, but the result is nice. You can see here after 12 weeks, an almost normal function of the shoulder in a very complex case. We call the modified Judea approach the same skin incision, the boomerang incision, but the modification of a Bransky is reaching the lateral pillar of the scapula in the interval between the teres minor and the infraspinatus. Using this approach, you can reach the lateral pillar of the scapula, of course, taking care about the circumflex artery of the scapula that can cause some bleeding and problems intraoperatively. We have to found this vase and ligate it to avoid and to prevent some problems and delayed surgery. But it's a very, very good approach and so much better, in my opinion, than the classic Judea approach, because you can preserve mostly the supraspinatus and the deltoid. We can't leave the deltoid intact for the vast majority of cases, reaching the lateral pillar of the scapula, as showed by Salasa and Peter Cole. If necessary, we can partially release the deltoid, but for the majority of cases, we can leave it intact, and we are going to gain to rehabilitate fastly our patients. This is a series of pictures of the group of the Scapula Institute from Professor Cole, and you can see here the deltoid, the interval between the infraspinatus and the teres minor, the lateral pillar of the scapula. We can reach the inferior area of the glenoid, and the medial column with a very thin, very tiny, a very small window and detachment of the infraspinatus to perform the reduction of the medial pillar of the scapula. And this is the paper that we published this month with Vincenzo Labranici and Felipe Serrão. This is free in the side of patient safety in surgery, and we address the whole scapula problem, performing an appraisal review of the literature and showing some cases and our way to treat extra-articular and articular fractures of the scapula. And the reduction of the great majority of scapular fractures, we use some simple instruments, such as a small diameter shank pin that is applied in the lateral pillar of the scapula, and we apply a traction in the caudal direction to reach the length of the scapula. And after that, we go to the medial column and perform 2 holes, proximal and distal to the fracture line, to apply a small Weber clamp to perform simultaneously the reduction of the lateral, that is generally the most displaced pillar, and the medial pillar, and we are going to simultaneously perform the reduction of the scapula body. And after that, we usually apply a hook, a bone hook, to pull this inferior glenoid fragment, or the avulsion triangular fragment that is very, very common associated with the scapular fractures, that actually an avulsion of the long head of the triceps tendon that has a region in the inferior glenoid part of the scapula. This is a case example. A male patient, 30 years old, very obese, suffered a car accident, a fracture of the odontoid process without neurologic problems, scapula and clavicle fractures, non-dominant limb, but he presented some years ago proximal humerus fractures, some degree of limitation of range of motion, and presented also at that time a rim fracture of the scapula, but of the glenoid, but without instability. This is not actually a floating shoulder. This is incorrectly classified as a floating shoulder, but as shown by Professor Jan Bartonicek from Czech Republic, this is actually an infraspinous fracture of the body associated with a mid-shaft clavicle. This is not, definitively not, a floating shoulder, and the reduction and fixation of the clavicle does not improve the reduction of the scapula in these cases. And this is the patient we did the modified Jude. He's very obese, and we performed the reduction of the lateral pillar using the foot set plates 2.8 to 4, and anatomic reduction in the medial column. We can twist and bend the plate to 3-5 reconstruction plate to reconstruct the medial column. And you see here the patient with reconstruction of the scapula. The patient with 2 weeks postoperatively, very good result in the early postoperative period. And this is a patient that I would like to share with you this case because I'm having some sound problems here. There is a microphone on. Thank you. This is a case, this is actually a patient with 77 years old. He is an elderly patient, but he's, despite of the age, he is very, very active. He lives alone in a farm. He works hardly, and he suffered a blunt chest trauma over the left side, and he presented a mid-shaft clavicle, displaced complex fracture of the scapular body, and several rib fractures and pulmonary contusion, and a small hemothorax. My initial approach was conservative treatment for this patient, but he presented a lot of pain, a difficult control of the lung problem and respiratory problems. And I have read this paper here that I'd like to share with you. That is the published by the Minnesota group, and the floating shoulder flail chest, acute management of an injury combination of the floating shoulder flail chest. The authors of this paper, they advocate that the restoration of the scapula clavicular arc, like you can see here in this illustration, can increase the improve the pulmonary function of the patient and decrease the time of intensive care unit and hospital stay. They have a very nice case series, and I decided to operate on my patient because of this information. I did the fixation. I recognize that we have several plates, maybe an overkill, but I like the fragment-specific fixation. And despite of several plates, the surgical procedure was not demanding. And this is the patient 24 hours post-operatively. And you can see here, the patient with a very nice lung function and with a very nice pain control for starting the early range of motion. So I strongly encourage you to read this paper and to think about the possibility of the restoration of the scapular-clavicular arc to restore the lung function of your patients. And this is the patient 8 days later, still with the stitches, like you can see here. And a very nice active range of motion after the surgical procedure. This is a male patient, 27 years old, association with a proximal humerus fracture. I know that my dear friend Sergio hates nailing the humerus. He is the founder of the Society of Protectors of the Rotator Cuff, but I did a nailing in this patient. I'm sorry, this is not I'm sorry, this is the patient, but I did a nailing in this patient. I'm not sure because the result is not here, but I did a nailing in the several plates to fix this fracture using the modified Jude approach. Sorry, the image is not here. This is a male patient where I have used the minimally invasive procedures to treat scapular fractures. This is a male patient, 40 years old, construction worker. Maybe I recognize that we don't have a huge amount of displacement in this fracture. Maybe this patient could be safely managed with a conservative treatment. I'm sure that probably he would be benefit of a conservative treatment, but see how we can, with a minimally invasive procedure, reach the reconstruction, the anatomic reconstruction of the scapula with a very small windows and very small detachment of the soft tissues. I put the patient in lateral. You can see here 2 small windows, reconstruction of the lateral column and the medial column with a very small detachment of the infraspinatus. And I love this plate to treat the lateral column fractures. This is actually a lateral malleolar plate to treat ankle fractures. This is very malleable, and it presents some options in the end of the plate to address screws in the inferior glenoid area where we have a better purchase between the screws and the bone of the scapula. And here you can see the reconstruction and the patient 6 weeks after the surgical procedure with a very reasonable result. This is another male patient, 28 years old, motorcycle accident, a distal clavicle fracture with a very, very small piece of bone, and scapular spine fracture, neck and body. Works as a floating shoulder, and 3 small windows, one for the clavicle fracture using a foot set plate to 8, and a lateral window with 2 plates to restore for restoration of the lateral pillar, and 1/3 tubular plate covering the triangular avulsion fragment of the scapula. Usually I suture the long head of the biceps underneath the plate in this situation, and we can address a long screw in the direction of the better area for bone purchase between the screw and the scapula. And here you can see the reconstruction of the fracture with a very, very good reduction. And this is the final case. This is a female patient with 34 years old. She's professional in mountain bike, but unfortunately she had a terrible accident and presented this segmental scapula, this segmental clavicle fracture, and a complex glenoid fracture with a huge amount of displacement and medialization of the scapula. She had a mild traumatic brain injury, and she had conditions for surgical treatment over, I think after 2 or 3 weeks, I'm not sure, but I tried to do it minimally invasive. Unfortunately, I don't have in my practice a long enough plate to address the segmental plate, the segmental clavicle fracture, and I have to apply several plates from the mean fragment set. I recognize that probably it's an overkill, several plates in the clavicle, but I preserved as much as possible the soft tissues the attachment, and the patient has a very reasonable result after 8 weeks. I recognize some atrophy of the infraspinatus, but she's doing very well in she's rehabilitation process to go to his previous activity level. So I'm finishing take-home messages. I'd like to tell you and emphasize that for the vast majority of patients, the standard treatment is the conservative that is safe and effective, at least for 80% of cases. I changed my practice in terms of association of floating shoulder, flail chest. I currently consider restoration of the scapulo-clavicular arc. I strongly advise you to use mini fragment plates for maintaining the reduction and increasing the stability of your construct when dealing with the complex fractures of the scapula. And I strongly believe as well that the minimally invasive procedures, they work, they are very nice, they are soft tissues friendly, but please start doing classic approaches before, because you need a long learning curve to start doing minimally invasive procedures. Thank you very much for your attention. Sergio.
Okay, can you stop sharing your screen?
Yes.
So see, okay, thank you for the nice lecture. It's something difficult. I'm just want to make some comments now. Hello, Parag, hope to have you here now. So the thing is, it's a difficult topic. I still say that to me, it's difficult. I just want to make some comments. The first of all is that Dr. Neeraj is one of the editors in Journal of Orthopedic Case Reports, in which Dr. Vincenzo has published that beautiful article. I want to make two comments and ask you a question, and Dr. Vincenzo and Dr. Parag, they can really help us in the answer. So the one comment that I think is very important, and there is a similarity in India and Brazil with difficult to very, I love the word you use it, fancy implants. I have a lot of difficulty in this in my public hospital too, in the public hospital in which I do my shoulder and elbow trauma work. So we use a lot of creativity here in Brazil, and this is what you are doing too, to use mini plates, sometimes from, as I understood, from hand kits
And then
or
food. And then food, mostly
and food.
Yeah.
Yes. So this, I think that this is a message for everybody. It's difficult to have those beautiful and pre-contoured plates from Acumed, as you show it. They are very beautiful, but very expensive. So we must use our creativity. This is one thing, and we are very good Brazilian guys in using creativity when we don't have the, I would say, the better implants or the most fancy implants. There is a learning curve, of course, and I fully understand that we should start with big approaches before doing with minimal approaches. But one thing that I have difficulty upon, and I really want you to answer, Dr. Vincenzo, please, and Parag, feel free to answer, is why when you have less than 22 degrees of the, in the glenopolar angle, you should do surgery. What the glenopolar angle means to all of us, I still have difficulty to understand it. I need your reply, and Dr. Vincenzo too, and Parag, as long as he feels okay, to give his thoughts to Dr. Robinson about the glenopolar angle. What does it mean? Why 22 degrees? I think that this is a very important question.
Yes, Sergio, it's a very nice question. It's difficult to answer precisely with 100% of
certainty,
of accuracy, because there are several papers showing that when the glenopolar angle is lesser than 20, is inferior to 22 degrees, we have a poor functional outcomes. Maybe because we have a combination of things. There are several papers with more than 10 years ago that publications, and probably the problem is a whole problem of the scapula. This is not only the glenopolar angle, because when you have the inferior glenopolar angle, you have usually a combination of some degree of angulation of the scapula. We have some degree of medialization as well, and you decrease the lever arm of your scapula and the length of the scapula. You can decrease the abduction of your patient sometimes. But in my opinion, there is a combination of things. The glenopolar angle is very famous, but in my opinion, there is a combination, a whole problem.
Yes, before Dr. Vincenzo speaks, just a comment. As I am a shoulder and elbow guy who does a lot of shoulder and elbow trauma, my mind is always coming to the shoulder and elbow universe. So just to make a comparison, we have, which is very famous now, the critical shoulder angle. And the main question is, what do I do with this information described by Dr. Gerber? So we still have some difficulty in understanding what to do with the critical shoulder angle. It means this and that. I'm not going to enter in the discussion because I don't want to change the topics. But as I understood, it means a combination of phenomena that would lead to a bad final clinical result. But still, I want to listen, Dr. Vincenzo, please, and Dr. Parag, the meaning of what does the glenopolar angle means and why 22. I'm sorry, I am insisting in the number. Vincenzo,
no,
please.
But you're correct. You're correct, because this is not well defined still. What we know so far is that we are very used to understand shoulder function. I mean, you know, proximal humerus head and the glenoid and the scapular angles. We are very used to talk about versions. So we know that we know about versions a lot of things, and we know from Pascal Boilet that there is a very combined mechanism between the anterior muscle, the subscapularis muscle, with the posterior two muscles, the external rotator muscles. This combination gives some sort of a balance in this function of the shoulder. But we are not very used to talk about the inclination of the glenoid. You know, we're talking about version, but we never talk about the inclination. And Robinson, I think he was very, very happy when he talked about
very fortunate.
Yeah. When he talked about the loss of the inclination is associated in 100% of times with some sort of a medialization of the cephalic fragment of the humerus, because it accompanies the glenoid neck and the glenoid fossa. And we are talking about version. So we are talking about subscapularis from the front, and we are talking about the external rotator from the back. But we are missing the whole of the supraspinatus muscle. And when we talk about some degree of medialization of the shoulder, we are talking about some loss of strength of the supraspinatus muscle. And this has a direct and very fast impact in the kinesia of the shoulder function. So what I think is that we have to evaluate a little bit better the value. Is it real 22 degrees? Is a little bit more, is a little bit less, but for sure there is some degree of very good importance in terms of inclination, not only version but also inclination. This is my thought.
And just another point before Dr. Parag gives his thoughts. This is very important. My life is to save rotator cuffs all of the time, as Dr. Robinson has mentioned. But the thing is, as I am understanding, when you have too much medialization of the articular fragment of glenoid, we would have a loss of strength in subscap and in supraspinatus, leading to important impacts on the kinesia of the shoulder. Am I right?
You're perfect, right. This is, I think, in my opinion, the main problem.
Okay, so which is the number? Dr. Robinson, your microphone is blocked. So the thing is, which should be, there are some other people with the mic on. I would request you to cut the mic. I don't know who is it, please. I don't know. I don't know if it's Dr. Sebastian Lopez or, okay, thank you very much. Okay, Dr. Robinson, which would be the number in which we should consider the medialization for us to think about surgical management.
Sebastian, please, your microphone is on. Please turn off your microphone.
No, you're listening to me.
Sebastian.
I just want to know, just a second, it never happened before. There are some guys here as the presenters with a lot of interference of sound. I would request you guys to turn off the microphone. I don't know who is it. We are having a lot of interference. I'm sorry, Dr. Ashok Shyam, can you,
Yes.
Okay, now it's good. So again, the question is very important. When we have medialization, we lose strength of the subscap, the supra, and it has a huge impact on the kinesia of the shoulder. Which would be the magical number of medialization of glenoid for us to start thinking about lateralization with surgery?
Sergio, actually, the medialization we consider, I follow the protocol of the Minnesota group, and I indicate surgeries for medialization greater than 20 millimeters, but
20
millimeters. But,
2 centimeters, 2 centimeters.
Yeah, 2 centimeters. But I consider 10 millimeters for double disruption, and 15 millimeters when combined with 30 degrees of angulation. This is a complex to keep in mind, but
yes,
this is the protocol that I follow.
Dr. Vincenzo, he wants to say something before Dr. Parag.
Yeah, but again, Sergio, this is these are values that we have to use and to evaluate for a longer period of time to clearly define if 20 millimeters is the division between surgical and non-surgical indication for a medialization of the glenoid neck. And again, if we need to operate on patients that have less than 22 degrees of the glenopolar angle. So these are initial measurements that were mentioned by the group of Peter Cole, but we have and we need for sure some longer follow-up with our patients with several publications to clearly define the real numbers. Are these the real numbers, or we have to change these numbers? But for sure, the version of the glenoid neck is very important, as mentioned by Pascal Boilet and others, but we have to look at the inclination angle of the glenoid fossa and neck.
Okay, Parag, your thoughts about these complex ideas?
No, so can you hear me now, Sergio? Am I audible?
Yes.
Excellent. So again, I agree with both the speakers, and it's a very complex three-dimensional anatomy with a lot of soft tissues as well with the deltoid and the rotator cuff. So I completely agree with the entire discussion and the fact that the inclination as well as the version are important for long-term good function of the shoulder. But again, the glenopolar angle of under 20-25 and medialization of more than 2 centimeters is something that I also take into account along with the age of the patient as well as what he or she does for a living, because you see some of these patients at a later date with some of the other problems, and we find incidentally malunions of the scapula, and at least at that point in time we can't pinpoint what's wrong because they're doing okay. But somebody who is 25 doing okay for 10 years, 15 years would mean that by the time he's 40 he's going to have some problems, which again is extremely young. So I think these are guidelines, and I would agree with you that whether it's 22 degrees or 25 degrees, it's practically impossible to really define and base your treatment on that. But the lesser the glenopolar angle, the more difficult the biomechanics of the shoulder are going to be.
This is a very important idea. I am getting it much better now. And one thing that I think, I have a lot of experience in proximal humerus, very complex fractures. And the thing is, we have to understand that malunions that can have a very huge impact in function, and they are much harder to manage than acute fractures. So the thing is, malunions of the scapula, when they have to be, I would say, corrected, that would be almost impossible. So we should think about it when we consider surgery too. I don't know. My question is very I would say straight, because this is the case that I'm going to show. Dr. Robinson, any experience with malunions of the scapula which should be corrected, because this is a very challenging situation. Vincenzo, Robinson, any clue on this? This is a very challenging point.
Sergio,
sorry, Robinson. No,
go
ahead. Sorry about.
No, Robinson first.
Okay.
Robinson first.
Okay.
No, Sergio, I don't have experience, at least yet, because I don't have any case of malunion of the scapula treated surgically.
God.
But if I have, I would consider a classic Judea approach.
Okay.
It depends on the patient concerns and etc. I don't have experience.
Okay, Vincenzo, any clues on this very difficult issue?
Sergio, I have some patients with malunions of the scapular body, mainly scapular body, but some with scapular neck also, with this loss of inclination.
Okay.
All of them were managed non-surgically. All of them were managed non-surgically because of the thought that this is a scapular body fracture, so this does not need surgical intervention.
Okay.
And despite of the huge angulation and displacement. And this is very difficult. In my talk, I'm going to show one case just to comment a little bit on the classic Jude approach. It needs a huge dissection. It's a lot of bleeding. So you increase the risk of postoperative complications related to this intense bleeding because of the muscles detachment. You have to have a very clear 3D thought about the whole scapular body. You lose a lot of bone. The scapula is a very thin bone, and when this is malunited, the bone is thinner than usual. So you have to be prepared to do a multiple level osteotomy in order to realign what is interfering with the kinesia of the shoulder.
Yeah.
So if it's the body, I'm going to show one case of a body malunion. You have to osteotomize in multiple pieces, like a puzzle. So you have to mount the puzzle using multiple plates, mini plates, small frag plates, lag screws, and so on.
Just one comment.
It's a difficult situation.
Very difficult, but just one comment for people to keep in mind. This would be the case, a very good indication for 3D printing preoperatively. That would be a lovely indication. So you see that in some cases, 3D printing has a big role in helping us, I would say, not understanding deformities, but making a better pre-op plan. I'm sure you agree with me. So let's move to your,
For sure.
Okay,
you're correct.
Okay. So let's move to your presentation, please.
Okay, thank you very much. So my whole here is very easy, mainly because, first of all, I know my dear friend and brother, Robinson, very nice. We work together for the last 5 or 6 years. So what he thinks, I think, and what I think, he thinks also. So it's very easy to talk after him. And moreover, he's a very good speaker. So it's very easy to understand all the points that he just mentioned to you, not only about indications, but also about approaches and also about tips and tricks to deal with this difficult situation of scapular body and neck fractures. So my whole here is a little bit different. I'm gonna talk to you about an easiest indication because this is an articular fracture. I'm going to talk about the glenoid fossa and ring fractures. So let me try to hold the PowerPoint presentation here. I apologize for that. So, okay. So this is my disclosure. I'm an international faculty of the AO Trauma Group and also a regional consultant for Zimmer Biomet in Brazil and Latin America. We know that, as Robinson just mentioned to you, scapular fractures are clearly and obviously related to high energy traumas. There is a high level of associated injuries. I mean, rib fractures, I mean, pulmonary contusions, hemothorax, pneumothorax, also some cervical spine injuries. So this is not an easy injury. Not only the scapular fracture by itself, but also the spectrum, the complex of the patient with a scapular fracture. In my surgical life, I use the Heidelberg classification to understand a little bit better the scapular, glenoid, and ring fractures. I think everybody is very used to this classification. It's a very simple classification, but you can understand what you need to do and also for which approach you have to perform your procedure. So the clear indications nowadays to me for operate on those patients is more than 4 millimeters of displacement of the articular surface in the case of articular glenoid fossa injuries. And for the ring fractures, I operate on all patients that have more than 25 degrees of involvement of the ring, of the periphery of the glenoid articular surface. In this agenda, I would like you to, by the end of the presentation, truly understand the surgical indications according to the fracture pattern. So it's not only 4 millimeters or 25 degrees for the ring, but also for when or where I have to go to solve the problem, and also to outline the surgical approaches based on this fracture location and displacement. I don't know what's happening here, so let's talk about the anterior approach. The anterior approach, I normally use the anterior axillary line approach. Less than 20%, less than 10% of all cases of articular glenoid injuries are in the anterior part of the glenoid. I mean, I use the anterior approach only for anterior ring fractures, the Heidelberg type 1A injury. You can see here the Heidelberg type 1A injury, and also the fractures that extend superiorly, including the coracoid process, so the Heidelberg type 3 fractures. In these fractures, I go from the front, just in these two type of fractures. The approach is very, I don't know what's happening here between my Zoom and my PowerPoint, so let's move and front and back. So this is the classic axillary anterior approach. You can see we do the normal dissection as we used to do in the Henry anterior approach. We protect the cephalic vein. You can see here the cephalic vein is right here. We use the Fukuda retractor to pull to the lateral and posterior direction the humeral head. And you can see here, this is an Heidelberg type 1 injury, type 1A injury. So it's very easy to see from the mid part of the glenoid fossa to the front. So you can see this whole part in the front. If we need a little bit more dissection, we can extend this approach a little bit more superior, so we can move and we can see very nicely the coracoid process, so we can also manage fractures that extend to the coracoid process, and it's easy to reduce. Now you see provisional fixation with 2K wires, and you can repair the labrum after your definitive fixation using whatever you want, you know, very small mini fragment screws, headless screws, whatever you want to use. So then you repair the capsule, then you reinsert or repair the subscapularis muscle, and I think all shoulder surgeons are very familiarized with this anterior approach. Let's see some cases. This is an Heidelberg type 1A injury. You can see that there is a small step here. You can see that always also there is some degree of displacement between this anterior part and this rest of the anterior part of the glenoid ring. There is a step here, but also you can see some degree of impaction. There is some degree of impaction you can see here because this patient had a shoulder dislocation. You can see the heel sacs injury in this part of the lateral and posterior humeral head. So we decide this is the CT scan. You can see, as what I just mentioned, the degree of displacement of the hinge fracture, but also the degree of impaction, the marginal impaction of the anterior part of the glenoid. You can see here in this axial CT scan cut. And we decided, I don't know what is happening here, sorry about that. We decided to go from the front. So again, the same approach using the Fukuda retractor. You can see here you can see the stitches in the subscapularis muscle, the mid portion of the subscapularis tendon. Here you can see the labrum. The labrum is a little bit intact, but you can see the marginal impaction here. After correction of the marginal impaction, now you can see the whole articular surface is again anatomic, and you use two mini fragment screws just in the subchondral bone to keep this fragment in place. And you can see in this, you can see here headless screw used to fix this fragment. You can see again now the ring of the anterior part of the glenoid is again anatomic, and this is the patient after, and this is the patient after 1 year. You can see a very good function, and you can see here the approach that we use for this patient, an anterior axillary approach. This is another case, a very interesting case. Again, you can see some degree of the anterior ring is again classified as an Heidelberg 1A. This is the CT scan. You can see very nicely the fragment of the anterior ring with some very small pieces of bone, some fragmentation, some powder bone here in the axillary recess. So we decided to go from the front, and this is an intraoperative image with the reduction of this anterior part of the ring with multiple K-wire temporary fixation. You can see the stitches here holding the labrum in position. Then use an anchor to reinsert the labrum in the superior part. There was some sort of a slap lesion here with the long part of the tendon of the biceps, and using this multiple mini fragment cannulated screws. And this is the final fixation after 12 months, a very nice reduction. You can see, and this is the function of the patient. Very nice stuff. I'm struggling with this PowerPoint presentation, Sergio. I apologize for that.
Don't worry about it. You can keep it.
Yeah, in terms of posterior approaches, we're going to use this for about 90% of all cases.
No, just a second. Just a second. I'm going to ask again for all the presenters who have recently joined the presentation to turn off the sound, because this is giving interference. I'm sorry. Please continue, Dr. Vincenzo. I'm going to turn my one too.
Thank you very much. So you use, for about 90% of all cases, we have distinct options of approaches. Robinson just showed some of them. So we can perform the classic Judet approach, and nowadays I prefer to use the mini window approaches. So I use this for posterior ring fractures, the Heidelberg type 1B, and all glenoid fossa fracture patterns except the Heidelberg type 3. So we can use for these type of injuries, and also the type 5 variants. the classic Jude approach, as Robinson, nicely mentioned, is a very huge approach with a nice and long flap dissection. You can see all the structure here. You can see the posterior part of the deltoid. You can see the infraspinatus, the teres minor, and this is the interval we can work using the variations of the classic Jude approach and the teres minor here. So we detach all the muscles from the lateral border. You can see very nicely all the fracture, but it's again, as very nicely described by Robinson, it's a very huge approach. And nowadays, as we discussed previously, I prefer to use this for malunited scapular, body, and neck fractures. Look at this case just to illustrate. It's out of the spectrum of our talk, but just to show when and how I use the Jude approach. You can see this patient was treated non-operatively, and the patient was unable to move the shoulder. You can see from the front in the AP view, we can see the body in the lateral view, despite of the AP view in the upper portion of the scapula and glenoid. And when we do the lateral view, we see the body from the front, the distal part of the body from the front. So it's an obvious malunited body fracture treated non-surgically. We decided to do an osteotomy, and this is the step-by-step of the osteotomy. You can see the bone loss in the mid part of the scapular body. We started to doing a lot of cuts. Then we mount the puzzle with multiple K-wires and faucet clamps. And this is the final fixation using what we have in Brazil. In the public departments, you use regular plates. We use lag screws. We use sometimes mini fragment plates, but that's what we have in our public hospitals in Brazil. And this is the final fixation of the patient. You can see now you see the whole body in the AP, and you see the whole body in the lateral view. Now you can see the body really in the lateral view. And this is the function of the patient after a lot of, I think this patient now has 11 years of post-op. The patient is very, very happy with this outcome. After that, I started to doing the modification of the Obransky, Bill Obransky and Jeff Lyman. Robinson also showed to you. You have to take care with this ascending branch of the scapular circumflex artery. This has to be located and ligated during the procedure, because this causes a severe bleeding, not bleeding that kills the patient, but disturbs the whole surgery and extends the surgery a little bit because of this. This is the interval that we have to work. You can see the deltoid here. You don't need to detach the posterior part of the deltoid. The infraspinatus, the teres minor, and the teres major. So we go in this interval. You can see the circumflex scapular artery here. This has to be located and ligated. After that, you can nicely expose the posterior part of the glenoid fossa and neck, and of course the lateral border of the scapular body, and you can work on that very nicely. And this is one case showing that. In the beginning, we thought this was an Heidelberg type 2 with this inferior apex of the distal part of the scapular neck and body. But when we did the CT scan, we could see that the fracture line extends to the body, horizontally to the body. You can see a huge fragmentation of the body here. So we decided to do this approach. You can see the step-by-step. I prefer to operate on these patients in prone position, not in lateral position, because I think the gravity facilitates my life in terms of reduction of the articular component and also the glenoid neck. So I operate on the patient in the prone position. This is the approach. So this is step-by-step. In the interval between infraspinatus and teres minor. This is the posterior deltoid. This is the ascending branch of the circumflex axillary scapular artery, sorry. So we ligate this. This is the ligature. Then we cut the artery, and now we have room to use clamps and to put some Homan retractors. You can see the fracture line going from scapula glenoid fossa to the body, and use this to hold the fracture in position. Now you can see the fracture is reduced. Use a log screw, a 4-0 cancellous screw as a log screw with a washer. And this is the immediate post-op reduction and fixation. You can see nicely the reduction of the glenoid fossa. Now you have the anatomic contour of the lateral border of the scapula. You can see here, and this is after 4 years, the fracture totally healed with a very nice articular congruency, and this is the function of the patient. You can see this patient used to play basketball, and now he still plays basketball. You can see the approach here, and you can see a very perfect function of the guy after this open reduction and internal fixation using the Bill Obransky and Jeff Lyman approach, variation of a classic Jude approach. Now I moved to use, let's fight with the PowerPoint here. Now I use this, I don't know what's happening here. Now we use this mini window approach with combination with the Brodsky approach. So many cases I use the Brodsky approach with this some windows of the Van Noort or some windows of the Peter Cole approaches. So we are able to approach where we need to go to reduce and to fix. So if we need to go to the lateral border, we do an approach to the lateral border. If we need to go to the medial border, we do an approach to the medial border. If we need to go to the inferior angle, we do an approach to the inferior angle. So we are trying to do mini window approaches. We have to take care. Robinson just mentioned that. This is a very good paper from the group of Peter Cole again. We have to know the anatomy and to take care not only with the anterior, the ascending branch of the circumflex scapular artery, but also with the suprascapular nerve that comes from the upper portion of the scapular spine to the distal portion of the scapular spine into the infrascapular muscle. We have to take care of this structure also. So we need to know these structures in order to use plates and reduction clamps and so ever. I like a lot to use the vertical posterior axillary incision described by Brodsky. It's the same incision as we just mentioned from the front. We do from the back. We go in the posterior axillary line. So we have the entire direct vision, not only from the glenoid, posterior glenoid neck and fossa, but also in the lateral, from the lateral border of the scapula. This is a very nice case. You can see an Heidelberg inferior fracture, an Heidelberg type 2. You can see there is a huge step off and also an inclination of the distal part here. You can see the fracture line extends from the front to the back, but the main component was in the posterior position. You can see here from the CT scan, the main component was in the posterior position. So you can see a huge inclination and step off. You can see here in the coronal cut. So in the 3D, we can understand where we can use the implants. Again, what Robinson mentioned nicely, the central part of the scapula has no bone. So we have to use the borders, the lateral border, the inferior angle, the medial border, and the spine in the spine here, in order to clearly accommodate and position our implants. So this is a provisional intraoperative fixation using the concept of provisional mini implant reductions and K-wires. Then we kept this mini implant as a reduction plate, as a definitive fixation or adjuvant fixation plate. And then you use 1/3 tubular plate here with long cortical screws, just, fixing the fracture. You can see intraoperative, a very nice reduction. This is the immediate post-op. You can see a very clear and very nice reduction. Look at this long screw. We have to position and to direction this screw to the coracoid process in the front. So it comes from the back to the front. It's some sort of a magic screw. It's a very long screw. And this is the postoperative immediate CT scan control, just to check the reduction, and also if there were no invasion, no penetration of the articular joint. You can see a very anatomic reduction here. And this is the x-rays after 3 years of this patient. He's a professional that works with physical education. So he's a personal trainer. He needs his shoulder, and he's very happy with this final outcome. Another approach that I like the most is a Van Oort small windows. Van Oort described with his colleagues a medial incision to address the medial part of the scapular spine and also the medial border, and a lateral mini window that needs the interval between the teres minor and the infraspinatus. So we work here in this interval, and it facilitates our life to address both these lateral fractures and these medial fractures. I'm going to show you to you a case. This is an Heidelberg type 5 variant A. You can see a very complex fracture. The patient also had humeral shaft fracture with a radial nerve palsy, a traumatic radial nerve palsy. So this is the fracture. It's difficult to understand. Everything is loose. Everything is completely disrupted. But we using this 3D CT scan, you can clearly understand the complexity of the injury. You have a fragment from the lateral border detached. You have a fracture of the spine, and also you have a fracture in the medial border that extends to the inferior angle. So we decided to do the lateral window of the Van Oort. This is the lateral window of the Van Oort. So we can see in the upper portion the infrascapular, the infraspinatus muscle. You see here the teres minor muscle. This is the spine. You see the spine here. You use mini fragment plates from the handset with 2/4 screws and 1/3/5 lag screw with a washer. You can see here the configuration of the plate. So the H plate is holding from the back to the upper portion of the spine. Then, using the same approach, we moved to the neck. Again, you use a mini fragment as a temporary reduction plate, then a 1/3 tubular plate. Then we did a second approach in the medial border of the scapula, and again we use a plate with 2/4 screws from the handset, just holding as a hinge the medial border of the scapular bone. This is the intraoperative fixation. You see here the position of the C-arm, just to check. This is the true AP view. Is this way we check the AP view. With the C-arm in this central position, we see the whole body. This is the false AP view, but we can see the whole body configuration. And now we move to the 45 degree of inclination to the medial part, and we can see the Y view. We can see the true lateral view of the scapula. This is the final immediate post-op. You can see a very good balance between the left and the right shoulder again. This is our approach, horizontal approach for the lateral and the spine fractures, a very short medial approach to the medial border, the plate that acts as a hinge. This is the X-ray of the patient after 3 years. You can see a very nice reduction, a very nice function. This is This is the patient after 3 years. You can see the approaches and a very nice function. And the patient is very happy with the final outcome. And the last case is about one thing that Robinson and I are very looking for nowadays. This is a very complex patient, a polytrauma patient with bilateral pneumothorax. You can see by the x-rays of the thorax. This is the thorax AP view. You can see a bilateral hemothorax. The patient got two chest drains, chest thorax for this hemothorax. And this is the concept that the group of Peter Cole are trying to introduce to ourselves, and they call this a floating flail chest. We call this in our paper as the scapular complex fracture association, because we have multiple associated injuries and a very complex scapular morphologic pattern fracture. You can see here from the CT scan, the actual CT scan, you can see a multifragmentary fracture of the glenoid fossa. You can see the extension and the intercalary segment of the body and spine. You can see here, but also you can see this patient had 7 ipsilateral hip fractures. So we decided to operate on these patients. In our hospital, we from the orthopedic department also fixed the rib fractures. So this is the 3D. This is the 3D reconstruction of the scapular fracture. You can see a very complex morphologic pattern of the glenoid fossa here, but also extends to the spine here, and also extends to the body. So we decided to do a posterior. Approach. So we did the Brodsky approach with the Van Oort variation. So we used 2 mini plates to fix the scapular spine here with 2 0 screws in this anterior posterior plate and 2 7 screws in the upper portion of the spine. Then you use a log screw for the scapular glenoid fossa and a buttress plate here in the inferior and lateral part of the border of the scapula. Then we move to the distal part. And with a vertical incision, we plate the inferior border in this oblique plate. So it went from the lateral and distal part of the inferior border to the medial hinge, to the medial border of the scapula, and using the same approach as the patient had 7 fractures, one of these non-displaced, so we consider 6 fractures. We decided to fix half of them. So using mini fragment plates to 7 screws, we fixed the most displaced fractures, and this is the final X-ray of this patient, and this is the lateral view. You can see the very good reduction of the inferior part of the glenoid, the scapular body, and also the ribs. And the patient had the opportunity to very fastly take this drain out, and the patient was discharged 3 days after this procedure with a very nice condition of the pulmonary function. So as a take-home messages, first of all, I apologize. I don't understand what happened between my computer, the Zoom platform, and also the PowerPoint. I don't know why this happened. I apologize again for that, but I would like you to have in mind that as other articular fractures, the spaced fractures of the scapular fossa need anatomic reduction and stable fixation. This is not different from pilon fractures, from tibial plateau fractures, from femoral head fractures. This is an articular fracture. I use in my practice the Heidelberg classification. So I think this is very useful to understand fracture pattern and to define which approach or which approaches I need to use to fix the fractures. Remember that 90% of these fractures are managed by posterior approaches, but we need to know also how to perform the anterior approach. It's necessary to have a thorough knowledge of all anatomical structures potentially at risk. I mean, the ascending branch of the circumflex scapular artery, and also the infrascapular nerve, the scapular nerve, the suprascapular nerve. And finally, that reduction is not necessarily dependent on huge direct vision. So I agree with Robinson to start using the classic Judet view, but as soon as you have a little of expertise, try to start using mini window approaches. It's much better for the patient, and it's not so bad for the surgeon. So start thinking of using this mini window approaches and limited approaches. Thank you very much for your attention, and again, apologize for this discomfort with this going back and front with my PowerPoint presentation. Thank you very much, Sergio.
Okay, so the thing is, lovely, lovely presentation. You deserve many claps because it's beautiful, 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 beautiful. I would like to spend 2 days, 48 hours. We are senior surgeons, but there are many juniors here, I know, because they talk to me all of the time. So I just would like to highlight some points before listening to Dr. Parag about his thoughts about this, and then Robinson, because there are many juniors here. First thing is that from a diagnostic point of view, 3D CT are very important, many times with suppression of the humeral head when possible. It's very difficult, but this is something that we should keep in mind. I love it, this position, which is the one I do, and I love it when Dr. Vincenzo showed how to position the image intensifier. For juniors, this is very important, okay? I love that. Another idea is that, as I'm gonna show in a case, sometimes in these articular fractures, leg screws, they are magical. They can do magic. And I'm gonna show one case about it. And the idea of using transient mini plates to help reduction and helping them and keeping them in the end is something that I'm learning with you guys. And now I am understanding why Dr. Robinson likes to put so many mini plates. I was seeing his cases in the article and I was hitting my head in the wall to say, Jesus Christ, I don't understand. But now I finally understood. So this is a message for everybody to keep handsets, foot and hand boxes. You understand, hand kits, foot kits, and to use mini plates to help reduction. It's transient as key wires, but it becomes definitive in the end. I think that this is a very nice idea that I'm learning with you guys. And by the way, the idea of using this combined, I would say, approaches that Dr. Vincenzo was mentioning as windows, really, it's really interesting. I did in one case, I'm gonna show it now. I am a little bit familiarized with the Brodsky approach, but we have these other ones. I didn't know this Van something. I didn't recorded his name, Van Nutz or something like that. But this is a lovely idea of doing combined, I wouldn't say mini incisions, I would say less morbid incisions in order to protect soft tissues. And another thing that I know is that the working horse is the posterior approach. So what Dr. Vincenzo has mentioned to the juniors is very important. Anterior approaches, which is variations of the delta pec, they are not the working horse. The working horse is posterior approaches. So lovely presentation. The thing is, I have heard about fixing ribs. I would be very afraid of causing pneumothorax in the patient, even if he has a drain. Okay, and before Dr. Parag speaks, just comment to us, Dr. Vincenzo, because I would really be scared about doing iatrogenes, even being a senior surgeon, as all of us, when fixing ribs. I would shake even of fear, even about thinking. So Were you with a thorax surgeon right at your side? How difficult it is to plate, in these cases, ribs, and which implants do you use to fix ribs? I think that we should only listen to you before Dr. Parag speaks about his opinions before his presentation. Dr. Vincenzo.
Sergio, it's a, you know, we do a lot of trauma surgery, Robinson and myself. So as trauma surgeons, we are very familiarized with multiple approaches, and we can work in a, fortunately, we can work in a multi-specialty hospital. This is a level 1 trauma center in Rio, as Robinson works in Belo Horizonte. So I don't need in my side, by my side, I don't need a thorax surgeon, but for sure, if I need someone very fast, they are in the hospital.
Okay, good.
This is not you know, I'm not incentivizing, I'm not stimulating junior surgeons to start doing that, but it's
Yes.
not very hard for trauma surgeons because, you know, the ribs are very superficial. It's not difficult to get in the bone. The hard job is to do the drill hole. So what I
Mm-hmm.
recommend the most is that you have to have at least two very nice and necessary instruments. One is you have to have a round, a circle. I can't remember the word in English, but it's not a straight Hohmann retractor. It's some sort of a
A
curved
mini Homan,
Hohmann retractor.
a mini Homan.
Yeah, but it's not a mini Hohmann also only, but it's a mini round Hohmann. So
Mm-hmm.
it's not a straight Hohmann, but it's a curved Hohmann. So you can move in the medial part of the rib. So you flip the Hohmann, and it wraps
Mm-hmm.
the rib, and it protects your drill bit when you, for example, inadvertently you go
To the pleura.
away from the other cortex. This is
Okay.
one thing. And the second thing is to use uh, uh, a drill bit that has a limiter. So
I
we
was
have
thinking
drill
about.
bit. Yeah. So in the preoperative plan, you measure the width of the rib. So in the OR during surgery, you regulate the width of the drill bit that you need just to touch the neocortex and the other cortex, the far cortex. So we are able to just touch the far cortex
And
to
you
do the
don't go far away.
puncture hole.
You don't go
Yeah,
far away.
and far away, and of course you have a round Hohmann retractor wrapping the mid portion of the rib. It's not easy
Just
to
one
do.
comment.
It's not, yeah, it's not easy, but it's not so hard to do it.
Okay, just one comment. When I'm doing a more difficult clavicle fracture, I do the same because there is the subclavian artery on the medial part. So I put something below, and I did it last week, and I shortened the drill, not for the first cortical, for the second. So in the first, you don't need it. You can do it, but you don't need it. But in the second, you put it just a little bit bigger than the size of the screw. I think that this is very important. But Dr. Parag wants to say something on your lovely presentation.
No, Sergio, Vincenzo, I think that's absolutely fantastic. So I don't have much to say, but just I just admired the entire presentation, and there were a lot of good tips on going about this. I use the same approaches for that, but for me, the more the complex the fracture, bigger the surgical approach gets.
Sure.
I definitely, I mean, most of the times I do not do the classical version of the Jude, but I take the same incision and then use all the windows that need for the fixation, especially the interval between the infraspinatus and the teres. Again, a word of caution for so many surgeons is that the infraspinatus is like a bipinate muscle. So sometimes you think you are in between the infraspinatus and the teres minor, but you're actually just splitting up the two heads of the infraspinatus. So I think it's just something to be aware of, and this interval is quite inferior than what you normally think. So I made these mistakes many times, and I was always in between the infraspinatus before realizing that I'm not actually in. So it's important to recognize that the infraspinatus is a bipinnate muscle, and you need to go beyond that. Sometimes you can incise the fascia over the muscle to get a good look at the muscle, and then gradually decide your plane. So go more lateral before you decide what plane you are into. And the circumflex branch is a bugger, and if it gets into bleeding, it retracts very fast. So again, as pointed out by Vincenzo, that you need to isolate it and ligate it. So I think that's extremely critical. But I think it's a fantastic presentation and a great collection of very complex scapular fractures.
Sure. And before Dr. Parag shows us his presentation and fractures after reverse, which I am very interested in, everybody. Two things. Dr. Vincenzo is a very important part of this presentation, but whenever he has to leave to a complex case in which he's the boss of the hospital, I hope he can keep just a little bit more. Dr. Robinson, any concerns before Dr. Parag presentation?
No, just congratulations, Vincenzo. You were absolutely fantastic. I know that you are about to publish the largest case series of glenoid fractures of the literature. I'm happy to contribute with you, my friend. You are an outstanding surgeon. I always learn from you a lot. Proud to be your partner.
Outstanding.
This is a very good friend. We learn from each other, Serge. We learn from each other. You know, I say to him that is some sort of a marriage, but it's a very good marriage. You know, we have no sex and we don't have to pay the same bills. So this is the perfect marriage.
The perfect marriage.
Thank you very much.
Okay.
Perfect marriage. Just if you allowed me just 1 minute,
Yes.
just to make a comment on Parag's comment. Thank you very much, Robinson, for your kind words. Parag, also, thank you very much for your kind and nice words. What I do is, I think this is a very nice tip. What I do to differentiate between the infraspinatus, as Parag mentioned, infraspinatus is a bipinnate muscle. So what I do to different, and I show to the residents, what I do to differentiate between the infraspinatus and the teres minor. Look at the directions of the muscle fibers. The infraspinatus is a little bit more horizontal, and the teres minor is oblique. And if you open the fascia, when you open the fascia, because when you start doing scapular fractures from the back, it's amazing. When you start doing the Judet approach, when you do the flap, you see the fascia, you are not able to recognize anything. You know, it's a little bit like, what I'm doing here, where I am, what I have to do now, because everything looks very equal. So as soon as you open the aponeurosis, the fascia, you are able to identify the horizontal fibers of the infraspinatus and the superior oblique fibers of the teres minor. So this is the interval. This is the interval. This is my tip for the residents. Thank you very much for your attention.
Oh, no. I would just mention that before Dr. Parag starts, I cannot compare my experience with Dr. Vincenzo, but I know this idea. The fascia between teres minor and infra is much more thicker than on the orthopedic approach. On the orthopedic is very easy to open, okay? And posteriorly, it's a troublemaker, but the thing is, as long as you know anatomy, you know where you are. And sometimes I have found some fat over there, and you don't know if you are in the fascia or still in the subcutaneous. But as long as you go and you open it slowly, the muscles appear in front of you. And this is the moment when whatever Dr. Vincenzo said is absolutely true. Dr. Parag, can you start?
So, Sergio, I might take a bit to just get my presentation because I've had an IT issue. So I'm going to load my presentation from my mobile device, and that might take just a bit of time. Okay, just give me a couple of minutes.
If you want, I can show my case, the one for discussion, and then we can put yours. What do you think?
No, I think I'm going to take the same amount of time, either before or after the case, because you know, I have to sort of load it up from my downloaded files and things like that. But I'd be more than happy for you to show your case first.
Okay, so even because Dr. Vincenzo can comment, I hope.
Absolutely.
Okay, so just a second. I need. Okay, so I'm gonna share. Vincenzo is already there, or he has already left?
No, I'm here. I'm here.
Oh, you're here. Hopefully. So the thing is, I just want to know: are you guys seeing my presentation now, or not?
Yes.
Are you? Yes.
Yes.
Excuse me. So are you guys
Yes.
seeing?
Yes.
Yeah. Okay. So the thing is, I want to show just to mention to all of the people who is connected to the link, and some people recently came to turn off the sound to, for us just to listen to the presenter, which in this moment is me. The thing is, I'm going to show one case very fast, but the second one was one of the most difficult of my life. And after many struggle, we ended in the lovely result. And I would like to hear you guys, Dr. Vincenzo, about the second case. And the first is easier, but it's very beautiful. So this case is about a 36-year-old man. 5 years ago, 2016, he fell from a scaffolding, a blown on the left shoulder, extreme pain. He went to our public hospital. This is the AP view, in which we can see a very big split in the middle of glenoid. Whenever we see it in a bigger view, we can see a superior fragment here and inferior fragment here. So this is the AP view, and this is the lat view. It's not easy to position these patients with so much pain. We need a 3D CT, of course. This is the AP view. I would say anterolateral. This is basically the AP view. In this case, as I have mentioned, we should, whenever it's able, to take out the humeral head to suppress it, but it was not possible in this case. Nevertheless, this is the beautiful posterior view, which is, by the way, the image in our folder. And I thought about doing, in this case, something like the Brodsky approach. It took me 5 hours, I repeat, 5 hours to fix this. I am not a fast surgeon. But the thing is, what I did a Brodsky approach, just as Dr. Vincenzo was showing. In my opinion, a leg screw, a cannulated screw with a washer was what really saved me. And I put a neutralization plate. This is what I have in my public hospital. I was really in doubt in this case. Should I put a second plate to distribute the forces? I don't know. I would like you guys to answer this when I finish. Intraoperatively, I did exactly this second mini window in a way that was my final construction. This is the AP view 1 week post-op. It seems to be a gap, but I guarantee to you guys that it was not. I had difficulties in understanding anatomy. You see many rolls here that I put in the wrong position. I don't feel bad to say this. There was no intra-articular gap. I can guarantee to you because I saw it. This is the lat view. So it was very difficult in rehabilitation. This is 6 months post-op, absolutely anatomical reduction. here is something very interesting, as Dr. Vincenzo showed. This is a perfectly positioned lat view. You see here the base of the coracoid. See how nice was my interfragmentary screw. And in my opinion, this was, I would say, the magic intraoperatively. The rest was just neutralization plates. This is the patient 10 months op, 10 months post-op. So it was really difficult to rehabilitate this guy, much edema, much pain, a lot of physio, but he was very happy, a very young man, absolutely normal external rotation. Internal rotation, as I'm gonna show, was just a little bit limited, not much. This is a non-affected side. And now I'm gonna show you the affected side, which is almost perfect, almost. But he was very happy. And now I'm gonna show you the two approaches, the Brodsky approach, the accessory approach, and he was very happy with that. I used many concepts that Dr. Vincenzo showed. But this is one of, now, this is what I wanna show you guys, one of the most heartbreaking cases of my life, with a lot of difficulties. Do you want to say something?
Yeah, can you allow us just for, for small comments? I think Robinson has.
No, your voice is very low.
Sorry, can you give us just 5 minutes for Robinson, Paraga, and myself, because I think this is a very illustrated case. If you can come back a little bit just to show the CT scan.
Okay, just a second.
No, the other one, the next one, the CT. Yeah, this is, I think, the main importance of using the Heidelberg classification. This is a type 4 Heidelberg classification. This is a complete scapular glenoid fossa fracture that extends horizontally to the mid portion, to the medial border of the scapula. So what you have is, I don't know if you can see my hand, you have a fixed proximal fragment and you have a complete loose distal fragment that suffers some muscle actions, some muscle deformation forces. So which deformation forces? From the inferior border, there is some traction of the trapezius, the
inferior trapezius.
The inferior trapezius pulling down this fragment. Also, you have a disbalance between the lateral and the medial muscles, so there is a little bit of rotation towards the rib, towards the thorax cage.
Okay.
So what you have to do, in my opinion, in this case, in my opinion, you have to go first from the medial portion.
Okay.
Because the medial portion is a little bit easier. You don't need a huge dissection. And as soon as you use a 2.0 or 2.3 or 2.4 mini fragment implant as a horizontal hinge in the medial portion, now you don't have anymore something like this. Now you have one of the sides fixed. What you have to do is just to correct the other side, the articular side, but you have the mid hinge. So as soon as you have the medial hinge, you do the Brodsky approach or whatever approach. I like the Brodsky approach the most for this type of fractures. So you're able to go to the lateral border, including the glenoid fossa, and not only to anatomically reduce and compress, but also to check for this small rotation. But if you malreduce the medial portion, as you are using a very mini fragment plate, you can, still with the plate in the medial border, you can give some rotation of the lateral border. It acts as a hinge, but it's not a very rigid fixation of the medial border. So you're able to still give some rotation of the lateral border. This is my thought in terms of either type 4.
But see, in this case, the 1 million question is how to reduce medially only by the mini approach without a second Brodsky approach? This is the 1 million question, and I need your answer.
You just have to use forced reduction clamp, because as you have a very nice medial border, including the spine, you can see that the proximal fragment is almost in the spine. You can use including the spine. So you can use 2 small holes to punctuate holes, and you can use a forced reduction clamp to grab these fragments, to bring all together, and also to correct rotation. Then you put your small plate as a hinge, and you go to the lateral side.
Okay.
So this is how I manage this Heidelberg type 4 fracture.
Dr. Robinson, any more clues? And Dr. Parag, because this is a very pedagogical case.
Yeah, I completely agree with Vincenzo. It's very, very important to address both windows. We have a more balanced fixation. It allows for early range of motion, but mostly Vincenzo told about the importance of a flexible hinge, because if we use the traditional locked 3-5 reconstruction locked plate, bent and twist over the medial column, the medial pillar, it may be a little bit rigid and it can impair the reduction of the opposite side. So it's important when you use mini fragment plates, you maintain some degree of flexibility to allow for correction of the opposite side. I completely agree. I would address both, but I think you did a very, very good job. And it's very important, Sergio. You told a lot about the magic screw, but this screw is very demanding. The 3D understanding of the scapula in our mind is not easy, even for experienced surgeons. And the positioning of the C-arm, it's horrible. It's very difficult to have the V view to address your screw under fluoroscopy view. It's very difficult to do it. Sometimes you do a lot and you have a very hard attack angle.
One thing that is very important is to keep the whole arm into the surgical field. The whole arm, because you use the shoulder and the elbow to also reduce the fracture. It was very helpful to me. So one message to the juniors: drape and have the whole arm involved in the surgical field, because sometimes it's like this, sometimes it's like this, and that helped me tremendously. Dr. Parag, before I show the other case, any points about this one? And then I'm going to show the second case, which was very suffering to my life.
No, I think very, very interesting and important points mentioned by Vincenzo regarding the classification of this injury. I think if you have access, 3D printing, these are very, very helpful. And sometimes we pre-contour the medial plate beforehand, so that when we have a limited approach, we still have the contoured plate for it to straight away go and fit nicely on the medial side. Again, the fixation on the medial side is only provisional to begin with, and then you go on the intra-articular part, and then once you have a good reduction, then you sort of tighten all the screws on the medial and the lateral border. That's the way I would go around doing this.
Okay, so let me show you one of the most difficult cases of my life. Just a second. Wait. Just a second. Okay, I'm gonna pass the whole case again. It's very fast, and then I'm gonna come to the second case. Just 1 second. Okay, now I just have to show 6 months, 6 months. Again, just showing the well-positioned screw on the base of the coracoid. This is the last one, and then let me show you the case. So this case, again, one of the most difficult cases of my life. 38-year-old lady. All my friends know that until the pandemics, I was going every month to the Amazon since 2011 to do a lot of shoulder work in the city of Rio Branco, Acre. I'm very proud of that. Many shoulders, almost 300 shoulders operated over there. But this girl, she lived very far away in the Amazon region. She has a spine of the scapula in the base of the acromion fracture. And 1 month to come to us. This is the Amazon, a lot of raining, floods, in a way that she came after 1 month. This is the AP view, 1 month post-trauma. When we see the AP view, we see here the acromion, and here we see the spine of the scapula. It was 1 month post-op. This is the lat view. And when we see here the lat view, this is the spine of the scapula, and this is the acromion. So an absolutely distorted anatomy, demanding, of course, a 3D CT. So here we are seeing the spine of the scapula. Here we are seeing the acromion. Obviously could not be left like that. Here we are seeing a posterior view, the acromion, and here the spine of the scapula. And when we see from a superior view, absolutely displaced acromion fracture. So what have we done? We did this approach, which is described by AO. I did it a little bit posteriorly and I loved it. You should reduce it with clamps, but what I did in this case was to enter with my index finger in the subacromial space, put it up together with the elbow. I'm very used to that. And then key wires, and then you decide what you do. This is what we did. This is the anatomical reduction. And then this is what we have done. It's important to remember, we are in the Amazon, not all implants were available. This is anterior for juniors to understand, lateral and medial for juniors to understand the positioning. We should have these implants, as Dr. Vincenzo said, but this is not in our real life, especially in the Amazon. So what we ended having was a small combi hole fragment, plate, small fragments. That was the best thing that we could have. In the end, we were happy with the construction, and we would do a very, very slow rehabilitation. I asked for a post-op X-ray that would be done in that hospital on the next day. But the patient is a mother of 2 kids. She desperately come back home, 200 kilometers. We would start rehabilitation very slowly. But after 2 weeks, the plate got completely loose. I was begging for images, begging on my knees for X-rays. We are close to Bolivia. Old school surgeons, they don't care about documentation, so I could have nothing in terms of imaging. A huge deformity. She was screaming of pain, and the local surgeons, they were really afraid about that. They had never saw this, so they were afraid of the skin, of the plate cutting skin. They were afraid of infection. I completely agree. So without asking us, they removed the plate and said, go to the capital again and see what they do. So after 2 weeks, you see, it's a lot of difficulty for locomotion in the Amazon. She came to us. You can see here the screw tunnels. We were back to 0 again. This is the same situation on the left view. This is the patient for reoperation. Okay, this is a big incision. I learned it in the United States. You cannot fix what you cannot see. Seeing is achieving. You cannot fix what you cannot see. Seeing is achieving. So we did this big incision again. This is the AP view. You can see the holes of the plate in the spine of the scapula. This is a fracture. Obviously, this is not a non-union. This is a failed osteosynthesis. This is the fracture again, not a this is a failed osteosynthesis. So here we did a fixation again with key wires, and we decided to do a tension band fixation. And this is the intra-op C-arm view. We were very happy with the construction. It was not difficult to do. This is intra-op C-arm view in absolutely axillary view. We see very well positioned key wires. This is the spine of the scapula with the acromion. This is what we ended doing, and we were absolutely sure that we should put graft. No artificial grafts. We are 2.5 kilometers from São Paulo, Rio, 2.5 kilometers from Belo Horizonte. We had to take it from the iliac crest, just as I do in my public hospital here. And that was so our final construction, a tension band wiring. Here we are seeing it with a lot of graft taken hands from the iliac crest. That was the final AP view on C-arm, and that was the final axillary view. I was extremely satisfied with that. I said, okay, in the morning, X-rays, because they don't do immediately after surgery, is beyond my control. So in the next day, all of the mess happened again. No X-rays, I had nothing. The patient said absolutely nothing. I have 2 children. I have to move to my city. And I started to beg for news. We are next to Bolivia. The people think differently. The local surgeons don't care about documentation. And after 1 month, I said, I give up. I give up trying to have news. And one day, maybe I'm going to have some news about this lady. So 1 year post-op, I received this video. 1 year post-op, you see a shoulder with 3 surgeries in 6 weeks. 3 interventions in 4 to 5 weeks. She was absolutely perfect. This is the video, absolutely zero pain. She was fully elevating the shoulder, as we are seeing here, fully elevating. Internal rotation was perfect. She was extremely satisfied, no pain, very good internal rotation. She was absolutely fine. And I begged for X-rays that never came, because these things, they are below my control. But the thing is, I'm sorry, they are beyond my control. So the thing is, we did a plate, it failed. It has to be taken by other surgeons. And after that, a tension band wire was what saved us. I learned a lot with this case. I don't know if I should have put a tension band before this. It was very difficult from a psycho-emotional point of view for the patient, to me, to the people in the Amazon, but it ended very nicely. And I would like to know from all of you, what could I have done different in this case, in spite of a very nice final clinical result in the end. Dr. Robinson, you can say whatever you want. You can shoot me. Now you can shoot me.
Of course not. This is a demanding case. This is a difficult case. It works, in my opinion, like type 3 Kuhn fracture of the acromion. It's there is an impingement of decreasement of the subacromial space. This is a difficult case because we don't have enough area for a good purchase.
And the bone is very thin. And the bone is very
thin.
Very thin.
The reduction of the first surgery was very good, but the implant is very, it's a very robust implant for that area, and you have just 2 or 3 screws to fix the distal area of the acromion. Yes. It's not enough.
Okay.
So I have some tips for that. I have some cases using distal radius plates. They have low profile. They are useful for.
You mean volar locked plate?
Yeah, locked. 2.4 or 2.7 plates. They have low profile. They have more screw holes for a better purchase, and they work a little
Locket
bit
screws
better.
and locket screws, huh?
Yes, locked screws. And you have another possibility. There is a publication by Switzerland group in the Colombian Journal of Orthopaedics, and the surgeons with an almost the same fracture, and they used pilon fracture with closer is with a format that this plate used for pilon fractures of the synthes. They had a larger footprint area to cover the acromion place, and you have several screw holes that you can cut. It's easy to cut, and you can bend the holes to apply screws at the same level of the acromion. It's very, very useful. And another possibility is combining the tension band over the plate. If you are not confident of using only the plate, you can combine the tension band over the plate, of course, a low profile plate.
That's new to me, Vincenzo. In the end, I was very happy. It's not easy case, I know, but what do you think about it? I was very happy in the end. The patient was very satisfied, but very tense case to me. Your thoughts. I know it's very uncommon, but your thoughts on not only what I have done, but on this case as a whole.
Sergio, if you allowed me just to come back a little bit, I think that before we talk about solutions and end results, I think you have to understand why the first fixation failed.
Okay.
And first of all, I think when you start studying the case, I think the first misconcept, if you allow me to, it's not a direct criticism. We are talking about the case as a brainstorm group. So yes. I think the interpretation of the first situation, the pictorial essay was not adequate. I think the patient had a clear non-union of the acromial spine fragment. Because you can see from the image in the from the intraoperative images that you just showed to us, there was a clear reabsorption of both portions, the medial portion of the acromion fragment and the lateral portion of the scapular spine. So I think in this situation, you really needed some edge revitalization, bone grafting, and interfragmentary compression, as you did in the second procedure. In the second procedure, you did exactly that. You use a tension band wire, a static tension band wire, and you put a lot of autogenous bone graft. And this went very nicely, very well. I think in the beginning, I think this misinterpretation was the problem. You really needed an interfragmentary compression with or without a neutralization plate and bone graft. What I would like to use in this particular situation, if of course the width of the acromion allowed me to do that.
Because it's very thin. It's very thin.
Yeah, but I could see that you used two 1.5 or 2.0 K wires. If you were able to use two 1.5 or 2.0 K wires, maybe you could have used also a long 3.5 cortical screw. If you could use a long 3.5 cortical screw as an intramedullary compression lag screw, so you would have a very stable with a cortical a long screw from the pelvic set entering from the acromion. You could use, for example, a reverse preparation of the acromion, because you could expose the lateral side of the acromion fragment using a 3-5 drip bit, you could come from the medial portion, from the fracture non-union side, to the point, to the tip of the acromion. Then you reduce that and you start introducing without any perforation of the spine fragment, because this long screw is very versatile and it bends. So you could use a long screw in the whole acromion spine segment, and add a 2-0, 2-3, 2-4, 2-7, even a 3-5 plate as a neutralization plate with a lot of autogenous bone graft. What you did was exactly that, just by using a tension band wire. Yeah,
Okay.
just by using the
But
tension. This is
the
my thought
idea,
about this situation.
no, okay. I wanna see if I did any mistakes or if I was equivocated. But the thing is, I was really afraid of having an acromial explosion with any intramedullary. I was really afraid. So I said, no, a tension band, okay. If I pass something and it explodes, the subacromial joint, which is a functional joint, would be with no roof anymore, and I would not be able to sleep for the rest of my life. So maybe I could have done a tension band wiring. But before Dr. Parag speaks, the thing is, from a conceptual point, the question is very good. It was 1 month old. Do you think that it was a non-union with only 1 month old? This is a very good question, Vincenzo.
For me, non-union is not a concept of chronological time, but it's a
Okay,
concept of biologic and
okay,
viability of bone fragments. If you can come back to the X-ray, to the initial X-ray again, if you don't mind, of course.
no, I'm
You
gonna do it
can,
now.
yeah, if you come back to the original X-ray, you can see several degree of resorption of both edges. You can see the rounded edges of both acromion and spine.
Okay, it's here. This is 1 month
You
post
can you
fracture.
can see you can see here. I cannot use my computer with the
The point,
the
point.
pointer, but
Yeah.
you can see here, if you look at the fragment of the spine, the medial segment of the spine, it's rounded, it's
Okay.
obliterated, so it seems like a non-union. Although,
Okay.
although there is a chronological time of 1 month, but this
Yes.
is the X-ray aspect of a resorption and remodeling of the edge of the fragments. So I would interpret this as a non-union. So I
Okay.
would add some bone graft as you did in the second procedure.
Okay. Okay. I just want to say again, I guess that someone entered with the link and we are hearing some noise. So I'm going to ask again for everybody who is with the link as the presenters to turn off it, because we are listening a lot of noise. Okay. Having said that, Dr. Parag, you have the last presentation. Can you do it?
Yes, just give me a second, okay? So I'm going to share. This will, okay.
No, I'm going to stop.
Sergio, sorry, but I really need to go. Dr. Parag, I'm sorry, because I would like to see your presentation, but for sure, this is not the first time that we can meet together due to our
Absolutely.
friend Sergio. Thank you, Sergio, for
Okay.
an invitation.
Thank you.
Robinson, my
Thanks a
brother,
lot.
good to see you always.
Good seeing you.
Thanks a
Vincenzo,
lot.
Vincenzo,
very much.
thanks a lot, and we are going to grasp you again. Okay. You will not
Okay,
run away
it's
from
my
us.
pleasure. It's my pleasure. Thank you, Ashok. Thank you, Parag. Bye-bye,
Thanks a
Robinson.
lot.
Thank
Thank
you
you.
very
Bye-bye.
much for your attention. Bye.
Okay. Parag, you
Yes,
have the last presentation. Can you do it now or no?
yes, I can do it now. Just give me a minute, and I'm going to connect. Can you hear me, Sergio?
Yes, yes, yes.
Okay, so
you can share your
this,
screen.
yes, but this is just give me a second.
Okay.
Okay, so again, I'm just you know, I've had some issues today, and I'm just struggling with getting my presentation done. But it will just be okay. Let me again share. Okay, again, give me just a second.
Okay.
Okay, so I'm just about there.
We are seeing your screen now.
Okay, can you hear me now?
Yes, we are seeing your screen. I don't know if it's loading.
I think somebody has paused my screening.
Oh, Dr. Ashok, are you there?
Can you hear me now, Sergio?
Now, yes.
Okay, so I'm going to need to be a little bit quick. I have some issues here with my presentation. So I'm going to talk about scapular fractures following reverse shoulder arthroplasty. And I must at this point in time acknowledge my very good friend Amol Tambe from the UK, who has shared some of his cases with me to make this presentation a little bit more interesting. Sergio, is everything all right now?
No, no, it's not running. We can see that it's loading. It is loading, but it's not running.
How about now?
No, we can see scapular fractures following reverse shoulder arthroplasty. But we see your mouse. It's a list of presentations. It's the screen of your computer, but it's not entering. I don't know if maybe you can even send this presentation to Dr. Ashok, and maybe he could post it. I don't know.
Okay, I'm going to try and share this again.
Okay. I'm not sure if Dr. Okay. Oh yes, now. You just go to the beginning, okay? Oh,
okay,
no.
Can you see me now?
Yes. Okay.
Okay, so fantastic. So I'm going to talk about scapular fractures after reverse shoulder arthroplasty. And I just had an acknowledgement to make because, a few of these cases have been sent to me by my very good friend, Amol Tambe from the UK. And hopefully this should make the presentation a bit more interesting. So as we all know that the reverse shoulders numbers are increasing day by day, and we are using them for a lot of different indications, starting from cuff tear arthropathy to acute and neglected trauma. And the incidence of total shoulder arthroplasty as well as reverse has increased significantly over the last 5 to 10 years. And especially it is the reverse total shoulder arthroplasty which has taken nearly the best, the highest number position in the recent past. Now, if we look at the biomechanics of the reverse shoulder and its prime indication, which was cuff tear arthropathy, there was a high riding head, which made it difficult for the deltoid to act upon this particular shoulder. So when you did a reverse shoulder arthroplasty, medialized the center of rotation and distalized the humerus, now the deltoid had a significantly better lever arm to start abducting and elevating the shoulder. In a reverse situation, once you medialize the center of rotation, it also recruits significantly more deltoid fibers for elevation and abduction. So in short, the deltoid in the reverse shoulder gets effectively lengthened, and it's more efficient in its own activity of abduction and elevation, and it does not need the rotator cuff to help it doing so. But unfortunately, there seems to be a price to pay when you have the deltoid, which has now been physiologically altered. So I'm just going to put my first case here. This is an 85-year-old woman with bilateral osteoarthritis of the shoulder, had a left-sided reverse shoulder 6 months ago. She was doing reasonably okay with the shoulder, but had an acute onset of shoulder and upper back pain with worsening of the function. She gives no history of trauma, and the immediate x-rays were reported to be normal. So we got a CT scan and which showed this particular scapular spine fracture, which we'll discuss a little later as to why it should have happened. But this was probably a stress fracture that happened because of an abnormal lengthening of the deltoid. So this was a situation where she had an acute loss of function and a lot of pain because of this acute fracture. Now, this is an 80-year-old woman who came for a 6-year follow-up. This is my own reverse that was done 6 years ago. She has absolutely no complaints whatsoever. But when we took these x-rays, we saw that there was an acromion fracture, which she was probably not aware of. She has never had any definite amount of pain, or she denies any history of trauma. But then there is obviously something going on here where she had a fracture at some point in time. And this was another reverse shoulder done in a 70-year-old male. And as you see here, there was a fracture at the base of the spine, at the junction of the spine and the acromion. And this again was a non-traumatic injury to begin with. So another one with a similar situation, a 77-year-old woman who had a good functioning shoulder for 3 years and then suddenly had an episode where she had pain and loss of function. So these are unique complications of the reverse shoulder. And one of them that we already know was notching of the neck of the scapula because of the altered biomechanics. And the one which we have been recognizing recently are scapular spine fractures occurring as a result of a reverse shoulder. So if you look at the incidence and when did we start to recognize these fractures, one of the early publications is from Zumstein, and they had a meta-analysis of reverse total shoulders between 1998 and 2008. And at that time, they had just an incidence of 1.5% of reverse shoulders having this complication. And then we had another publication from Levy in 2013, where they presented a rate of 10% of scapular spine fractures. Now, something changed somewhere between the mid-2000s and the late 2000s, leading to these kind of fractures with reverse shoulder arthroplasties. And I think a few of the things that happened during the mid-2000s the decade of 2000 to 2010 was a shift from or development of other prostheses from the Grommet type, which initially actually had notching, and there was a shift from an inlay to an onlay design. So I think this was probably one of the things that, in my mind, seemed to have resulted in an increased incidence of scapular spine fractures. So if you look at the prevalence of scapular spine fractures in the literature, till 2013, we have 10% cases in this particular series, about a 7.2% fractures in Hartrup series, and a very low incidence in cuff series presented in 2008. It's interesting that both the Levy series and cuff, they've used the same DJO prosthesis, but have significant difference in the prevalence of scapular spine fractures. And this is based on the Levy classification of scapular spine fractures, where this fracture is, Sergio, very similar to your fracture of the lady from the Amazon, if you can see at the junction of the acromion and the spine. But they have classified this into three different types, starting from the acromion to the spine, and then to the base of the spine. So this is a type 1 fracture. That's a type 2 fracture here, and a type 3 fracture happening right at the base of the spine of the scapula. So it requires identifying these risk fractures to know why these fractures have happened. And these are some extremely good presentations in 2020 suggesting all the various risk factors in patients having scapular spine fractures after reverse shoulders. So a lot of things seem to be implant related. So if you distalize the humerus, as you need to do in reverse shoulders, that leads to a risk factor. And Rothman suggests that excessive lateralization, both of these are features of onlay design of a reverse shoulder arthroplasty. And in an onlay system, if you have an acromio-humeral distance of more than 3.5 centimeters, then you have more than 3 times incidence of scapular spine fractures as in comparison to an inlay design. So I think this is one implant-related change that seems to have led to an increase in scapular spine fractures. So this was one of my own cases. This is an elderly woman, and we have done a reverse nearly 3 years ago. And this was the measurement that we made, and this was almost 3.9 centimeters of distalization. So I think this was an at-risk shoulder of getting a scapular spine fracture. And this was when she came for the other side. So the acromio-humeral distance on the other side was about 1.5 centimeters, and the one on the ones we have already operated is nearly 3.9. So I think inadvertently, this is definitely significantly more lengthened, although you see excellent function of this reverse shoulder arthroplasty. So again, we did a reverse on the opposite side, and we did the measurements. Even on this side, she was significantly distalized, but at 1 year from this fracture and 4 years from the opposite side, she does not have a scapular spine fracture. But this is something to think about, especially in elderly patients, to not excessively distalize the humerus. But in some of the implant designs, this actually becomes a part of the procedure, and I'm not sure how you can control the distalization in this system unless you think of changing it to an inlay design. Neifeller believes that there has to be some trivial trauma that leads to a scapular spine fracture, and according to them, the design of the reverse and makes the lateral acromion sort of more superficial and more exposed to trauma and susceptible to fracture. So this is again something to look at. But again, 50% of the patients in the world literature do not seem to complain or remember a definite episode of trauma leading to these fractures. A very important observation is the presence of the base plate screws in the region of the base of the scapular spine, and these can actually act as stress risers and eventually go on to have a fracture right at this age, this level. So type 3 fractures are the fractures happening right at the base of the scapular spine, and we must try and avoid these screws getting so far posterior, or maybe completely avoid putting all the 4 screws and avoid one which might be going posterior. So these are the risk factors. So you have older individuals, but this is why you do reverses in elderly individuals. There is a higher incidence of scapular spine fractures in women as compared to men. There may be pre-existing osteoporosis. And the other risk factors that have been described are previous acromioplasties, as have been done for cuff repairs. The cuff arthropathy actually itself is a risk factor, because to begin with, you have a very high acromiohumeral distance, and then you distalize the humerus is significantly, leading to increased stresses on the acromion and the spine of the scapula. And people with inflammatory diseases like rheumatoid arthritis may also be at a higher risk. So what are the treatment options? A lot of people have stressed the non-operative management, primarily because we don't really know how these fractures are going to behave once they happen. There may be spontaneous union. There may be persistent non-union, which may be asymptomatic or which can be symptomatic, and then you can fix these fractures if your patient is symptomatic enough. So this was the case that I first showed you. This is an asymptomatic acromial stress fracture. This is more lateral than the spine of the scapula fracture. And this lady has absolutely no symptoms at all. And we are quite happy to continue in the same scenario with ignoring the acromial fracture. Again, this is a spontaneous healing of a type 2 acromial fracture, and it went on to heal. But this appears to be unusual, given the literature, where spontaneous union is not that very commonly seen in scapular spine fractures after a reverse shoulder arthroplasty. Now, the symptomatic non-unions are the ones where you might want to go in and do an operation. And this was again a Levi type 2 fracture at the junction of the spine and the acromion. And this again is a case sent to me by Amol. And these are the fancy plates that you in the Amazon and I in India don't really have access to. But the whole idea is to show you this, that a double plate, which actually could have been a good option for your case of acromial spine fracture as well, Sergio, to fix this kind of non-unions. And if your conservative treatment fails, and if your patient is symptomatic enough, then you may make a case of doing a plating of this particular kind of fracture. And this was the case that I began with, this 85-year-old lady. Again, as you see here, there are screws going right up to the base of the scapular spine. And this is quite common, that this can act as a stress riser, leading to a scapular fracture. So this lady is 6 months down the line, and in this X-ray, as you can see, this is a non-union. She has a significant fall or poor function on the left side as compared to what it was before this fracture, but she's now relatively pain-free and declined any further surgery because of her age. So in conclusion, the impact of scapular spine fractures in the reverse shoulder arthroplasty is mainly detrimental. So the fractures that occur lateral to the acromial base may have a good result, but if you have a fracture at the base of the scapula, then the results are significantly poorer. And this is the same finding from many other series, that more than 50% of the patients were unsatisfied with the outcome if they have a scapular spine fracture after a reverse shoulder arthroplasty. So I think these fractures are relatively low in incidence as of now, like about 4 to 5%. But I think with the increasing number of reverse shoulder arthroplasties that we do, I think it's a complication that we need to recognize, because once it happens, it's difficult to get the patients back to their original function. So thank you, my friends. Obrigada, Sergio, and thank you for this wonderful seminar.
Lovely. You see, I want to make some comments. You see, first of all, even being a shoulder surgeon who does so many rotator cuff work, I never thought about this, which is very obvious. I'm not sure if we can prove, but the previous acromioplasty may be a risk factor for a fracture after a reverse. People have to understand that many times reverse is not the first surgery of that shoulder. Many times reverse is done after some attempts or a failed osteosynthesis. We know that in a failed osteosynthesis, we don't have acromioplasties, of course, of proximal humerus. But this is something interesting. And even after rotator cuff arthropathy, the acromion may be a little bit suffered. This is something for us to consider, but it's not a contraindication, of course, for the indication of a reverse. This is very interesting, okay? And the thing is, I think that we have many problems when it happens. Only something that I'm going to keep in mind is that we are obsessed as shoulder surgeons to get inferior tilt of the glenoid component. And many times this inferior tilt leads to a screw that will be in the base of the acromion. And that may, yeah, the scapular spine, and that may be something that can lead, I would say, to some stress forces that can, I would say, enhance the chances of such fractures to occur. So in this sense, I'm going to pay more attention in my reverses, not to have so long screws. This is something that I think that we may pay more attention on. But the difficulties is that when it happens, we have a huge tendency, I guess, even from a psycho-emotional point of view, not to fix these fractures for many reasons. The patient has already been into a big surgery, which was the reverse itself. We are talking about osteoporotic bones in the vast majority of the cases, and many times it's difficult for the old patient, as a rule, to accept a new procedure. So it's not easy. It's really not easy. Dr. Robinson, it's not easy. The best scenario is never to have these problems. But having said that, Dr. Robinson, any clues about it, my friend?
Well, Sergio, as an orthopedic trauma surgeon, I don't do actually replacements in the shoulder, but I have my partners, they do it very well. But I have a special interest in this topic because I am seeing this fracture more commonly currently because of the increasing number of replacements of the shoulder, of course. And you told the hot topics and the Dr. Parakshat showed the most important things about the mechanism of injury, the possibilities of changing the lever arm of the shoulder, the length of the scapula, the easier exposure of the acromion to be more amenable for a fracture. And the biggest problem you told about the psychological impact on the patient and the poor quality and on the surgeon too. Another surgery and the traction of the deltoid, and it's a terrible combination. Very high expectation because of the arthroplasty, and a very disappointing fracture, a periprosthetic fracture. That is a terrible combination. But I have a special interest in this topic.
No, I know. And the thing is that I haven't had one so far. I hope I never get it. But the thing is that one thing which is very important, and Dr. Parag Shah, he knows it as I know, or even better than I know, because he has much more cases that I have already done. But the thing is, when you have a well-indicated reverse arthroplasty and well done, the predictability of the result, Parag, is very high. It's good.
It is.
It's very high. So you give a lot of expectations, not maybe for a wonderful, but a good result, especially in terms of pain, and function many times is, I would say, surprising. And you give it to the patient, as a rule, is an old patient. So there is a big family, and there are, I would say, a daughter, and the family is with a lot of expectations. And in the vast majority of the cases, we reach such expectations. And then after 2 years, you come to a very frustrating scenario in a way that the family will not blame you. But from a psycho-emotional point of view, everybody was happy, and then bye, and it's very bad from a psycho-emotional point of view. I always say this, But the thing is, it's not as a polytrauma in which you have an infection after so many surgeries. It's easier for the patient to understand independently of all the sadness. But in these cases, you have a big family, and the patient, as a rule, with osteoarthritis, the old patient was suffering for such a long time. So then you have a lot of happiness and then a mess. So you see, from a psycho-emotional point of view, it's very bad. So you have to talk a lot with the family too. Do you agree, Dr. Parag? It's difficult from a psycho-emotional point of view.
It is indeed, and again, for a lot of patients, there is also a huge financial burden
Yes.
getting these arthroplasties done, and then to add to that perhaps the possibility of another operation. And again, some of these spine fractures in the elderly, and you're not really sure that they're going to unite. And I think that's one of the reasons why in the literature you see that there is not a lot written about going in early and fixing these fractures, because you're not sure of the result, because the dilemma
even
is
after surgery. Yeah, even after surgery, you mean?
Yes, even after surgery, because your deltoid pull is still going to remain the same, because you still have a reverse. So whether you do a whole revision and change to something which is less tension, and then again fix the scapula. So I think this is an area where we need to be sort of aware right from the beginning, to see that these are best avoided.
Yeah,
and so I think one needs to think about how we put the screws in, and probably direct more of your superior and anterior screws towards the coracoid.
Yes.
And perhaps have polyaxial locking screws, so that you can even change the direction of some of your screws, and
more
things
superior.
like
And so what you're saying, Parag, because I'm learning a lot with that, maybe we can think about the direction of the screws of the glenoid component in order to make something as a prevention of these fractures in midterm. So this is absolutely new, but it's something that I'm going to think about.
Although Neifeller in his series, which I presented, they have 9 fractures, but they believe that there was no screw in the fracture zone of the base. So that's just of a contrarian view that has been published as compared to various other series, which suggest that there is probably. But I think it's wise to avoid screws in areas where they can act as stress risers and probably give rise to.
But this is something new, and the thing is, we don't hear too much, hopefully, about this spine of the scapula fractures, acromion fractures. The few that I have listened to, hopefully they heal it conservatively. And even if you think that if you operate it, is osteoporotic bone, and then you would think about putting graft. So graft, it would have to be, I would say, from the industry, because taking graft from the iliac crest in an elderly, Dr. Robinson, it's a mess, okay? So see how many, and then from that would be another economical burden, because the family would have to spend money. So you see, it's many steps of problems in this situation. It's not easy, orthopedically, biologically.
So again, from what I went through, more medial the fracture, the lesser chances it has of healing spontaneously. That's my belief. I do not have evidence to present, but if you think about it, the more medial the fracture, the greater is the amount of deltoid which is involved in the fracture. So if you have a fracture which is more lateral at the junction of the acromion and the spine, or if you have a fracture of the acromion, then it's only the middle deltoid which probably is dysfunctional, or it's the pull of only the middle deltoid. But if you have a fracture at the posterior,
Okay, so
if you have a fracture which is more medial, then the entire posterior deltoid and the middle deltoid will pull the fracture fragment and displace the fracture, and probably making it difficult to heal spontaneously.
Okay, so the thing is, see, my friends, we are 3 hours down the line. I would like to keep it for more 6 hours, but unfortunately we can. I think that we can finish now because it's 3 hours is a good time. The thing is, I am very happy with this webinar. Very happy indeed. I think that it's a difficult topic. All the lectures were nice. I'm happy I showed two interesting cases that made me understand more stuff, and I guess that all the audience could learn. It's an honor to have all of you guys, which I consider basically my brothers, Indian brother, and two Brazilian old one, which is Dr. Robinson, and a new one, which is Dr. Vincenzo. I just would like to thank you too much and listen to your final considerations, Dr. Robinson, and then Dr. Parag, before we finish this. Dr. Robinson.
Sergio, thank you very much. It was an amazing experience. We had a lovely webinar addressing the challenging scapular fracture. I love this topic, and you know that. And I learned a lot from you. Thanks, my friend. Thanks, OrthoTV, Dr. Ashok. Dr. Parag Shah, it was a pleasure to hear your presentation and to look at your presentation. Very nice to meet you. Thank you very much, everybody.
Okay, well, you know that Parag is in home in OrthoTV and in India, but so he's very comfortable to speak. But Parag, again, thank you a lot. I would like you to know that this is not the last time also, because I'm gonna grasp you again in future for other things. But I just want you to say your final considerations, please.
So, Sergio, thank you so much, and thanks OrthoTV for this absolutely wonderful webinar. Scapular fractures is not something that's talked about every day, and Dr. Vincenzo's presentation and Dr. Robinson's presentation absolutely great, and it has given me some food for thought in terms of how these fractures. I showed you one bad case just a couple of days ago, and we do get these fractures every now and then, with more frequency than what we used to before. So thank you once again, and it's been an absolute pleasure to be a part of this. And I hope people who've logged in have had the opportunity to take something important with them in their practice.
That's the idea. That's the idea. All of us to learn. I always learn here. I always say that when we teach, we learn. When we teach, we learn all of the time. And I hope that all of the audience liked it. I am already thinking about other webinars, and soon I'm gonna make all of the, I would say, the announcements, but to keep it not only in the Indo-Brazilian Shoulder Planet and OrthoTV way, Shoulder Planet and OrthoTV, but also in the Ibero-America. Dr. Robinson is invited, and Dr. Parag, we are also gonna grasp you for OrthoTV Ibero-America. Now you're gonna speak for 20 countries, not only to Brazil. Just give us some time. I don't know if Dr. Ashok is there. If not, I'm gonna finish. Dr. Ashok, are you there? Because he would have to leave for an emergency. Dr. Ashok, are you there? If he doesn't come in 5 seconds, well, he's not here. He had to leave. So it's a pleasure to have all of you guys here. As I always say, namaste, and Dr. Robinson is doing namaste too. Thank you a lot, my friends. This is gonna be in the internet soon. Much probably in 2 or 3 days, I am gonna spread it to all of my friends, but much possibly in my YouTube channel, in YouTube channel of OrthoTV, and you guys can spread it to your own friends as long as you wish. And it's an honor to have this. It's a beautiful opportunity for us to learn, and I think that we should continue this, I would say, non-stop, for the benefit of the whole orthopedic Brazilian, Indian, and international community, okay? So that's it. Bye-bye, folks. Bye-bye. Thank you very much. Thank you. Thank you.